I feel Dr. Bala Venkat is around. I feel he's traveling, na? So Virendra Sharma, Dr. Diwatiya sir, any of them are around, then they can just start off.
So, good evening, everyone.
Yeah.
Welcome to the next PPF webinar of the month of April. And today we have got a very important topics of medico-legal aspects, and we none better than the faculty today who will be sharing their wisdoms, pearls of wisdom with us. I think it will be one of the very educative webinar. And later on, you can see this webinar as a recorded version on YouTube at ISA NHQ. So whosoever misses some part of the webinar, they will be able to see it later on also. So without wasting time, I think it's better to start the webinar. So I hand over it to Dr. Pankaj. So you please start with the introduction of the faculty and the webinar, please.
Yeah. Good evening, dear friends. People from all over the country have logged on to this webinar. When we started this series of private practitioners forum webinars every month, we've been trying to inculcate the idea of safe practices in the country. We came out with our position statement at the Patna conference, and to implement it, we have continued the discussion. And in continuing with safe anesthesia practices all throughout the country, we hope that these such webinars can be useful to all our members. Medico legal, when I feel anything comes regarding medico legal, the first person that I have always contacted is Dr. Kane madam. To introduce her, I feel she needs no introduction really, but she's a senior consultant at Jangir Hospital, Pune. She has done her LLB, Masters in Personal Management and Healthcare Communication. She has many publications and chapters in books, and she has really helped me a lot in bringing out the position statement the way we have brought it out. She'll be discussing on decoding the dynamics of documentation with special emphasis on electronic medical records. Over to you, Kane madam.
Thank you so much, Dr. Okay, can you see my slides, please?
Yes, ma'am.
And yeah, just this. No, what has gone? Something has gone.
No, just the recording has stopped, but it's again started. No
Can you
problem.
see my slides?
Yes, ma'am. Perfect.
I can't see them actually.
Yes. It's already been, it's seen, madam.
Okay,
Your Zoom must have been minimized.
Ah,
okay.
right.
Yeah, all right. Thank you. All right. So this is really a very, very important and relevant topic, especially in our situation where we have landed up today. My topic is decoding the dynamics of documentation. There's something wrong with my screen.
Just double tap. Do the double tap by cursor.
Okay.
Double tap कीजिए. Yeah, it will move now.
Okay. You can see my slides, right?
Yes, ma'am.
Okay.
It's not moving.
It's not
Just
moving.
double tap on the screen. Do the double tap on the screen. Do double tap.
Okay.
Yes.
All right. Okay. We are so passionate about our clinical work and very, very proud of our technical skills. But when it comes to documentation, we really find it very burdensome. And we delegate it to our juniors, we sign without verification. But this attitude of neglect towards documentation is dangerous in the present litigious landscape. So litigation against doctors, everybody is experiencing, is increasing at an exponential rate. 5.2 million medical legal malpractice cases up to last year. And the Institute of Law and Medicine has said that improper consent, which is also a part of improper documentation, is responsible for around 60 to 66% of cases which get decided against doctors. So I want to emphasize that documentation is the only evidence of our correct standard of care, and it is our primary shield or the only formidable defense that we have. So let's start with a little bit of basics. So it is an ethical and legal duty of the treating doctor to create this evidence of continuity of care. And now the NMC 2019 has also emphasized this. Now remember that the responsibility of the content and its accuracy is entirely on the treating physician. So when you sign off on any document, that means you are stating that you have verified that it is true and up to date. Today, documentation include everything related to the patient, the clinical photographs, videos, audio recordings, printouts from monitors, emails, text messages, even bills are being admitted or used as evidence. Now, there are two things which I really want everybody to understand, that medical documents, whose property are they? So doctors, the settled principle is that the physical or electronic records which are generated by doctors are to be held in trust by them on behalf of the patient. The data which it contains, that is the sensitive health information of the patient, is owned by the patient himself or herself. And doctors are supposed to ensure this confidentiality. And this can only be breached in reporting child abuse under POSCO, reporting infectious diseases, and under the orders of the court, the criminal proceedings, road traffic accident, mental status confirmation, and labor courts. Another important issue to understand is patient privacy. So this is related to the patient's autonomy and control over their health-related matters. So a patient has the right to control how her or their personal information is used, collected, disclosed. It also, please, includes the right for physical privacy during examinations and treatments. So the patient needs to be adequately covered. They must not be exposed whenever you are examining or treating patients. The patient has a right to his documents, and any request that is made by the patient for his documents, the NMC has said that we have a period of about 72 hours to release these documents. But please remember, in case of any criminal litigation and FIR, the police can come and seize your documents at any time. Now let us look at some documentation deficiency which has led to litigation. So in this case from Chennai, the CPR, a young patient has a cardiac arrest in the recovery room. CPR notes were not written, so it has been held as res ipsa loquitur, 57 lakhs to be paid. This is another case where a laparoscopic hernia took 5.5 hours, and the patient remained unconscious afterwards, died, shifted on a ventilator and died later. The deficiencies were that there was no documentation of what the cause of the delay in surgery and why the patient suffered any hypoxic brain damage post-operatively. Surgeon and anesthetist held negligent, 15 lakhs awarded. This is another case where a patient had anaphylactic reaction to antibiotic. And the deficiency was that the history of allergy was not recorded. Also that the test dose was given was not recorded. And look at the compensation, 51 lakhs to be given to the patient, 75,000 monthly to be paid to the kin. This is a very interesting case of 2023. A patient admitted for LSES given GA as there was a spine deformity. On induction, patient has a cardiac arrest and dies. The anesthesiologist notes say that it was due to allergy to thiopentone. The postmortem shows a fractured pelvis with a large hematoma and a liter of blood in the abdomen. This is most likely to be due to a fall from the operation table. And the National Commission has awarded 1.6 crore compensation to be paid by the hospital and the anesthetist. Surprisingly, here the gynecologist got away by saying, I haven't even touched the patient. Anyway, the more important lesson is that fabrication of documents or a cover-up may not usually work. There is also a very important saying which say, alter the records and you lose your case. As far as possible, our records should be as close to the truth as possible. Now, storage and maintenance of records, according to the Ministry of Health and Family Welfare, IPD records must be kept for 10 years, MLC records till the conclusion of the case, OPD records for 5 years. Now, the NMC has given a different year, that is to be maintained for 3 years from the last date when the patient was seen or the treatment was given. Now, we can all understand that preserving physical records is an unsustainable challenge. Large storage spaces are required. The content is so fragile, the nature of paper, that fire and water damage can easily destroy everything. Now, it's difficult to retrieve. You can see from behind that if you want to retrieve data, it is so difficult after many years. So digital health record is an inevitable evolution. There is also a great push from the central government and the Ministry of Health and Family Welfare. So there is the National Digital Health Mission was announced on 15th of August 20. And there is the Ayushman Bharat Digital Mission, there is Abha, and the NMC is also now advocating moving towards digitalized health records. So what are the benefits? So the benefits are mostly it overcomes handwriting errors. It overcomes problems due to incomplete records because it just doesn't allow you to turn the page unless those fields are filled. So it is efficient for transferring information to all health providers. You can access it from remote locations. It is easy retrieval for the patient and easy for research data. But the most important is that it ensures efficient billing. Now, what are the downsides? The downside is usually for the doctors and the patient. There is a pressure of getting entries in time because you just have about 24 hours, depends on the system, 24 hours to edit or enter. After that, you leave an audit trail. So the doctors will have a learning curve and it is then becomes stressful to make those entries in time. It is also a time-consuming process. They say it takes about, depending on which system you are following, 6 clicks of a mouse to order a simple blood test. So thousands of clicks you have to do per day. But what about the patient? Patient is totally dissatisfied because the doctor is facing the computer, not the patient. And the patients feel that the doctors are not listening and there is not enough face time. So what has it done? So doctors all over in the developed countries are facing a stress and burnout due to the digital health records. Now, why is that? Because the doctor is accountable for accuracy of the digital health record, and also the payments are related to the digital health record. For example, if you do not write that you have inserted an arterial line, you will not get paid for it. And not just you will not get paid for it, the hospital will not get paid for the insurance company will not pay for that arterial catheter or whatever else is required for the art line. So actually, very surprisingly, they have said that AI is the answer and the doctors are using AI to fight burnout. there is a medical record summarization by AI. That means whatever I'm saying, the AI is going to, we have seen actually that the AI will summarize it and give it to you. But is that really going to solve the problem? Look at this. The errors that can come, inaccurate entries, typographic errors can persist permanently in the patient's records till somebody finds them out. Empty fields can get auto-corrected with incorrect information, compromising patient care. Improper selection from drop-down menus by healthcare staff can result in significant patient harm. They have, for example, if the patient is pregnant and your technician or whoever the nurse is filling the initial format says no instead of yes, and you would be giving them teratogenic medications, because you will never be able to know whether that is correct or not. Similarly, there is a case which they say became very famous, that the nurse, she asked, have you taken tetanus injection? And the patient said no, and she has entered yes. And she was not given this tetanus injection, and actually she died of tetanus. So you can see what serious problems can come with simple errors. Then artificial intelligence systems that we may be using, they may just omit some critical clinical information that they don't recognize. So if they are not trained in it, they will just miss it out, okay? But what is most important is that we are making decisions based on wrong information, whether it is due to human entries or AI entries. Next, the new DPDP Act has come, and we are responsible for preventing and safeguarding against data breach. So here we are, the patients are data principals, they own the data. Then so this does not cover the actual physical documents, but if the physical documents have been scanned and made into digital format, those are also covered. So now doctors are data fiduciaries, and we cannot share any information without the patient's express consent. They are going to be consent managers. Now, if there is a breach of data from our phone, computer, server, insurance company server, data management co-server, the patient is going to blame us because they have left that information with us. We have created that data. Our technicians, our staff, our AI program, all that we use can share data without realizing the consequences. And let's see what they are. Health record is the most sought after by hackers and cyber criminals. A stolen health record is valued more than a financial record in the dark web market. Now, India ranks second in cyber attacks on health systems, and this is a report from 2021. AIMS has seen a large breach. The lab data and patient records of very high security persons were hacked. Similarly, in 2023, the CoWIN data app portal was hacked. In fact, the chief of CoWIN, his own data was exposed via the Telegram app. Now, this exposed data is related to physical health, mental health, organ donation, organ transfusion, sexual inclination. These can be sold for fraudulent research, pharma targeting, cause harm, violence, discrimination, threats, extreme social embarrassment to individuals. Now, let me share this case with you because this is so important. So 3 doctors, the anesthetist was doing a cesarean section. The patient delivered triplets, and a photo was taken and shared, okay? Seemingly innocent act, okay? Now, this is September 2023. He was booked under IPC 354. Now, today that would be Section 77 of BNS, that is voyeurism, and the IT Act. Okay, and this is up to August 2024. So almost a year. The Kerala High Court has not allowed that FIR to get squashed. A simple sharing of documents. In criminal cases, mobile phones can be confiscated and used to get information. The information is admissible in court as primary evidence. So today, even if you don't take anything away from this webinar, please delete all patient data, patient records from your mobile phones. If you need some data, it must be securely kept on your PC with a password or some extra security. Please, I have stopped taking photographs for surgeons and sharing them on WhatsApp. Okay, I was told to cover consent, but this is a very short time to cover consent also. So I'm just going to tell you how a video consent is to be taken. A video consent is the best evidence of counseling. Okay, so the consent, there has to be either a physical form, or when you are recording, you have to say that, okay, I am going to record this, record your consent, and it is required so that there is no misunderstanding, and we need to, you need to understand better, and I need evidence that I have done the counseling. So you can say a single word like, you give the information and ask, have you understood? And so the purpose of the video is to take the consent. But for that, you need infrastructure to record, save, and retrieve. You cannot just have it on your phone, because phone, I feel, is one of the most dangerous devices that we have. Then it must be usually in an AV room, and patient privacy and confidentiality must be ensured. You cannot have just a female patient giving consent. You must always see that some other, either, some relative or somebody is with that patient in the video. This video has to be saved and, in some secure place. So do we have laws? These laws are quite outdated and really not keeping up with the technological advancement. So we have the BNS, we have the Information Technology Act, the Clinical Establishments Act, and the Ministry of Health and Family Welfare. But now the new data is the Digital Personal Data Protection Act of 2023. It is putting an extra responsibility on doctors who are collecting sensitive data. So we as data fiduciaries, we can only process it lawfully. We have to collect data. When we are collecting, we must tell the patient what we are collecting it for. We must minimize the data that we are collecting. It has to be accurate personal data, and we have to store it properly, and we have to give reasonable security. So the patient has the right to information correction, erasure, grievance redressal, and right to nominate. Extra special provisions are made to protect children. So when we are collecting data of children, we have to be extra careful that it is secure and there is parental consent, and it is not exposed to activities like profiling, tracking, and targeted advertisement. So, and the consequences of data breach from any of our devices is about 200 crores. I mean, it's really, really very heavily penalized. So there are two penalties. One is for breach, and the other is if we do not inform the board, that there has been breach. Along with that, the legal action, the patient can sue for damages in case there is personal harm due to data breach, and medical licenses may be at risk for repeated privacy violation. So I would, okay, sorry. I would like to just conclude by saying that let us give documentation their due respect. They are the backbone of our defense, whether they are physical or electronic, and we have an additional responsibility that our patients' data is like crown jewels, which they have left in our custody, and we have to ensure that we have kept them secure. Thank you very much.
Thank you, madam. As always, very informative and lot of new inputs. I mean, I remember 20 years back, we were hardly maintaining records or writing notes in private practice, especially. Now that those things have at least been brought in order, I think the next thing is going to be maintaining medical records. I feel that is what is going to become important in the future. And all of us, I feel, other than managing the patient, will have to be trained more in, how to manage the record. I feel looking at the fallacies that can come up in maintaining records. That itself, I mean, and a fine of 200 crores. God, medical practice will have to be really thought of. I feel it's going to be so difficult in the future. Thank you,
That is why
madam.
I said that, yeah, let me just do records, because it's really now becoming very, very important.
Yeah. Yeah, but I feel digital health is going to be the future. Only we have to be very, very careful in the operation theater. I feel as an anesthesiologist, we should stop taking photographs. And I mean, those cases that you mentioned were
I
really.
just take photographs with the surgeon's camera. I say, I'm not touching. No, and
Great.
please remember that everything which goes on social media is free for everybody to see.
Yeah. Thank you, madam. Thanks a lot for a very nice talk. I invite our next speaker, Dr. Shivkumar Kumbar. Dr. Kumbar is from Dharwad, Karnataka. He's done his LLB, LLM, MBA, MA in journalism. He's a postgraduate in medical law and ethics. And he's done his certificate in dispute management also. He's very active in the state IMA at the same time as ISA. And he just finished his term as the president of Karnataka. I requested sir to talk on something like unfortunately, if you have had a death on table, what are the precautions you should be taking when you are discussing with the relatives? Over to you, sir. Please go ahead, sir.
Yeah, thank you, Dr. Pankaj. We, the anesthesiologists, got into this practice because we value the life and we want to save the life of the people. What do you do when you cannot save the life? How can you deal with these emotions? Yeah. 1 second. I'm mobile. Yeah. 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 Mishap or death occurring on any table where the patient is undergoing any procedure, maybe medical, surgical, or maybe some delivery under the care of anesthesiologist, or patient dies before the surgery could be completed, or at the end of the otherwise technically perfect and successful operation is called as a death on the operation table or a mishap on the table. So anesthetic deaths occurring within 24 hours of the administration of anesthesia due to causes related to the anesthesia are also responsible by saying that there is an anesthetic death. So what are the places where table death can occur? It can occur on a operation table, maternity table, medical procedures where LP, epidural, central line, chest procedures, etc. are being done. Then where in radiological procedures where CT or MRI done under sedation, procedures done under local anesthesia, and also where the ECTs are commonly being done in many of the neuroscience centers. So the causes of on death table, human error is the factor in anesthesia practice, and the circumstances tend to be immediate, adverse, and conspicuous. Nowadays, a perioperative death solely due to anesthetic error are mercifully rare occurrence, but known to occur in our day-to-day practice. The extremes of ages, elderly and infants, patients are most common in this, and associated comorbid conditions from ASA grade 3, wherein the death on the table is 1.8%, and ASA grade 5, the death on the table is 9.4%. So surgical factors like aortic, thoracic, upper abdominal sites, emergencies in cardiac and neurosurgeries, increased bleeding, and compromised patients that tend to have a death on the table or mishap on the table. Especially anesthetic factors, as the anesthesiologist, yes, many times is the overburden on the part of the anesthesiologist, overdoses of anesthesia, wrong labeling of the drugs, wrong routes, accidents during intubation, anaphylaxis, inadvertent hypoxic mixtures, malfunctioning of the machines what you routinely use, and hypoxia, aerial problems, malignant hyperthermia, and lethal effects of propofol. These are the common causes where the mishap or death on the table can occur in our day-to-day practice. So what is the immediate reaction of the anesthesiologist? Yes, cardiac arrest in OT, 90% are reversible with immediate CPR and with visual monitoring by the anesthesiologist. Check equipment, drugs, debrief OT team, and accurate records is most important. Dealing with the anesthesiologist, senior concerns should stand by the side of the anesthesiologist in a crisis, which is our moral and we are duty bound to our colleagues. Dealing with the dead patient, it is a procedure-related death. Fast documentation is important, and facilitate transfer of the body to the mortuary, escort the deceased to the theatre suite exit as a mark of respect, give chance of relatives to pay their last respects. Many times what happens is we delegate to the hospital staff or the nurse or otherwise to shift the body to the mortuary till the police will arrive. It's a wrong concept which we are doing in many of the hospitals. And many times when the death on the table occurs, you have a tendency to run away from the scene, including the surgeons, never ever do it. And immediate cover-up and unnecessary explanations not warranted. Settle the matter as early as possible by political or financial means. Never do it. And being too confident is as damaging as too defensive. You have to be careful. Retaliate the abuse by the abusive language. It's not advisable. Be calm and quiet and compose your temper. Many times we are confronted wherein otherwise also we have been called, is it necessary to inform the police whenever death occurs on the table? No, it is not necessary. There is no law or judicial principle or pronouncement in support of a belief held by the many doctors that every death on the table should inform to the police. Not at all. The basic principle is that doctors should inform the police as soon as they suspects the foul play, including the unnatural death, during the course of his duties, whether in OPD or otherwise IPD, including the death on the table where circumstances are so warrant. It goes without saying that every unnatural death should be informed to police. Yes, then what is unnatural death? There is no reason for a doctor to inform the police unless the foul play is suspected. So when the foul play is suspected, then there is an unnatural death occurs, we have to inform the police. So foul play, no doubt you have to inform the police, and death on the table cannot be unnatural death. So, however, the relatives are within their rights to make police complaint if they want. If they don't believe the cause of death is given by you, yes, they have a right to inform the police because they are not happy or the cause of death is not acceptable to them, and there is a foul play on the part of the hospital or anesthesiologist surgeon for which they may have to complain to the police for the make it MLC. The police may get postmortem done if really want looking at the circumstances. Then, as I said, what is unnatural death? A death caused by external causes, example, injury or a poisoning, which includes death due to intentional injury such as homicide or suicide, and death caused by the unintentional injury in an accident manner. So death on the table can never be, and can you hear me?
Yes, sir.
So it cannot be an unnatural death. In Haryana Medicolegal Manual 2012 does not give any instruction regarding the death on the table. It is surprising that the belief continues that hospital must inform the police about any and every death on the table, which in my opinion is not acceptable. Rather than inform the police about every death on the table, what is needed of the concerned doctor is to ensure that the doctor's documents are proper, complete, and well preserved so that they can be produced as and when required by the police and in the court. So, CRPC 40 earlier, CRPC 40 talks about unnatural death, and CRPC 174 and 304B also deals with the unnatural death. None of these sections and the case laws related to the same suggest that death on the table is an unnatural death. So we need to interact with the police if there is unexpected death on the operation table. The expected death, no doubt, because we know the cause of death is readily acceptable by the relatives. But if at all there is unexpected death on the table, what we must do? It is our duty to inform the police, written or by phone. One must note down the bucket number and the designation of the police if at all you are calling him on phone. The police perform the Panchanama as an investigating officer as a routine and hand over the papers after numbering to the police or investigating officer. So the questions arise before starting autopsy by the investigating officer is, was the informed consent was taken? Yes. Was the operation and anesthesia necessary in the circumstances? Was it elective or emergency? Was it expected or unexpected death? Was there a proper PAE? Was the patient suffering from comorbid conditions? Whether OT was equipped with the proper infrastructure or not? Were all functioning or not? Was there a defect in the surgical or anesthesia technique? Was it acceptable? Was the hospital equipped to handle emergency situations? These are the questions which are investigating police officer from the police.
Dr. Srilekha Mankher, please switch off your audio. Dr. Mankher, please.
Going out of hand, we need to inform the police. Involve only the responsible person from the aggrieved family. Be a patient listener to the allegations and abuses because we should not counteract those abuses. Be calm and quiet. Take time to prepare the case paper and put proper notes. Cooperate with the legal arms or investigating team. In case cause of death is known, certify the cause of death with the cause of death. Ideally, post-mortem is advisable. The reason is OT is a restricted place with limited accesses. All measures of saving the patient are done inside the four walls, which always arouse doubts in the minds of the relatives, and we have to accept it because it is a restricted area. So, by routinely informing the police about the death on the table, what may result? Many people believe that death on the table should be informed to the police without any hesitations. It causes unnecessary delay in the OT work, unnecessary workload on the hospital administration, unnecessary workload on the police also, unnecessary likely harassment of a relative by the police, unnecessary possible hint to the police that they can boss over the doctors. So, keeping in this mind, if there is a genuine case, then only inform the police. If you know the cause of death, need not inform the police. So, the autopsy, when it is needed, the autopsy PM is being requested by investigating agencies like a police under previous IPC 174, CRPC, and magistrate under section 176 of CRPC with the following objectives. To find the cause of death is the main thing. And if you know the cause of death, you don't have to worry about that. To find the factual objective medical information for law enforcing agencies, to determine the manner of death, and to know the time of the death. So, who has to waive off the post-mortem? Medical legal PM is done on request of the police or magistrate or any court of law. Medical officer has no power to waive off the post-mortem. He can play the role of advisor in such cases by producing all documents or circumstantial evidences, but final decision lies with the investigating officer, that is none other than the police inspector. The police only being the principal investigating agency and the rightful custodian of the body after being informed to the police, because after being informed to the police, it becomes the property of the state and has the authority to waive off the post-mortem, talking to the people on both sides, looking into the case papers and taking the circumstantial evidences also. He can opt for the post-mortem or he can waive off the post-mortem. So, consent or permission of the relatives is not required for conducting a medical legal post-mortem. Many times you say that relatives are not giving consent so that we are not doing the post-mortem. This is not acceptable. So, breaking the bad news to the bereaved family. While communicating with the relatives, transparency is important, but good communication does not necessarily mean tell all to the relatives. As I said, you involve a senior member of the team, resolve the family members at the ICU, inform the family about the death, briefing about the patient's critical illness and what has been done to save the life of the patient, and facilitate the grief reactions, arrange for viewing the body of the deceased, help the relatives to go through the official formalities without any hassles. So once the cause of death is not being accepted by the relatives because of the unexpected death on the operation table, they have these remedies. They can go to Consumer Protection Act, they can file a criminal case, they can complain to the administrative authorities, local as well as the district basis, complain to the state medical council for disciplinary action. They can invite the media to tell that something has gone wrong, and they can demand the money. And violence against the doctors is very, very common when there is an unexpected death on the operation table. So what about the death certificate? If you are sure of the cause of death, you can safely issue a death certificate in a prescribed format and avoid PM. In case there is a slightest doubt in your mind and minds of the relatives, that is which is not acceptable cause of death by the relatives, it is always safe to inform the police. If the PM is really required and relatives are refusing for it, it is best to inform the police, make it an MLC and hand over the body to the police for further compliance as per their guidelines or as per their complaints what they routinely do while doing a Panchanama. So this is a very interesting case. Relatives denying the postmortem, what you must do. In Sir Ajay Chakrabarti versus Dr. Srimati M. Mahbulindra Nandi, State Commissioner of the West Bengal in 2019, the important to record the post-mortem denial by the relatives of the deceased patient. So here the doctors advised the post-mortem, wherein the relatives did not agree for that. They said that because of the religious grounds, we want to take the body on our own and do the cremation. So there is a religious problem in us, so that we want to take the body, we don't want any post-mortem, which was written in the case paper. After the burial of the cremation of the body, the relatives went to the police station and also said that doctors to hatch up the things that did not do the post-mortem. Here, doctors' diligence in the record keeping saved them from an adverse verdict, and it was in favor of the doctor. There is nothing wrong by the doctor's side. It was only the relatives who accepted the cause of death, and also they did not want the postmortem to happen because of the religious grounds. There are few cases wherein the cause of death, whether PM is required or not, has been very well explained in these cases. Especially in Keshav Yadav versus Dr. JVS Vidyasagar in 2021, Belgaum, Karnataka, wherein an orthopedic surgeon was to undergo arthroscopy in a workshop at Belgaum. The anesthesia was given by his own friend, Dr. Sawant, who accompanied the orthopedic surgeon. When the OT was setting ready, and also when the workshop was about to start, the orthopedic surgeon was given spinal anesthesia by his own friend, Dr. Sawant. Soon after giving anesthesia, or spinal anesthesia, the patient had a respiratory problem, severe bradycardia, hypertension, and it could not be revived. And it was about to be declared dead, but ultimately the patient was shifted in an ambulance, well-equipped ambulance, to the Kane hospital, wherein they declared that patient was brought dead. So they filed a complaint in the National Consumer Court in 2021, stating that death on the table occurred and course of compensation being asked. The anesthesiologist, who went to the acute depression soon after losing his friend, who is the orthopedic surgeon, he committed suicide by injecting himself propofol or pentothal with the scoline, and soon after the mishap happened. So the National Commission said that the patient relatives failed to to convince the court that there was lacunae or fault in the hospital administration or surgeon. And they said that just even the scrubbing was not taken place, patient had a cardiac arrest, automatically there is no role of the surgeon being involved over there. Since the cause of death is because of the spinal anesthesia, which is not known to occur in some cases, and also the anesthetist died. So automatically the case against the anesthetist stands nil. On these grounds, the rest of the physicians, cardiologists, they did their best to revive the patient after the cardiac arrest. There is nothing wrong in the procedures being done while reviving the patient. Ultimately, it's unfortunate the patient died, and there is no negligence on the part of the hospital as well as the surgeon. This is what the verdict of the National Consumer was that. In one more case where Srimati Sampati, wife of late Samit Lal Sharma versus P.K. Sharma in 2017. Again, they awarded compensation of 25 lakhs, wherein abscess was to be drained. The spinal anesthesia was given by the surgeon himself. So in some cases, routinely would come across, especially in the minor procedures like CT and MRI, wherein death on the table or imaging table occurs, which is not acceptable even with the sedation or induced by the ketamine or propofol. There's a few of the cases wherein death has occurred and they have done a post-mortem, and ultimately the anesthesiologist was held responsible, but not reviving the patient sufficiently because there was limited resources. Thank you one and all.
Thank you, sir. Thanks a lot for bringing out very intricate points, which on the precautions we should be taking if you have had an unfortunate death on table, and also before informing the police, whether to inform the police or not. That itself, I'm sure there are already questions in the chat box.
Yes, sir.
So we'll take the questions at the end of the session, sir. Thank
Sure.
you. Thanks for a very nice presentation, sir.
Thank you.
And it will continue during the discussion, I'm sure.
Yes.
Coming to the next speaker, Dr. Hemant Gangolia. He is a very senior pediatrician from Neral. He has authored various books such as Medical Negligence in Pediatrics, Medicolegal Problems and Solutions for Practitioners, Medicolegal Issues in Intensive Care, and he has also written various chapters in various books. He is a reputed speaker at state and national conferences. Also has been the past president of Maharashtra IAP, and also organized medical legal conferences. Sir will be talking on criminal litigation in anesthesia practice, liabilities under MTP Act, POXO Act, dealing with the police, FIR, and arrest. Over to you, sir. You can start screen sharing, sir. Dr. Hemant.
Thank you very much, Dr. Pankaj Gupta, sir. And at the outset, my heartfelt thanks to ISA, in particular, Dr. Pratibha Kane, madam, Dr. Pankaj Gupta, sir, and the office bearers, the organizing team, to give me the opportunity to share my thoughts on the criminal litigation in anesthesia practice and the liabilities under MTP Act, POXO Act, dealing with police, FIR, and arrest. So it's a very huge topic to start with. I will try to cover in a short time. You can mute Dr.
Dr. Haran Khedkar, please mute yourself.
So this is a topic which is a huge topic. And to start with, this everybody knows, but the point important I want to say is that there are a lot of gray areas. Medico-legal issues are part and parcel of one's practice. One has to accept it, and one need not get afraid of it, but one has to be careful by knowledge and by experience. So to start with, this position statement which I read for anesthesiologists in private practice and hearty congratulations to Dr. Pankaj Gupta, who is the National Coordinator PPF of ISA. And just I will ask whoever is attending, anesthesiologists who are attending this webinar, have you read all these pages of this book? Fantastic book it is, and it covers the basic of anesthesiology practice. key is to read word by word and redefine one's practice. And I think so. If everybody read this book, almost 75% job is done. And the important areas which it covers, and I think so it's already highlighted by Dr. Kumbhar sir as well as Dr. Madam, Dr. Kani Madam. Documentation only defense in court of law. Consent should be real-time, informed, justified one. Various forms are there. Stationery for records, fantastic. I have gone through the booklet, the equipments, what are needed, drugs required, and the emergency management. May I suggest to Dr. Pankaj Gupta sir and your association, if possible, as guidelines are not mandatory, but they are to follow, to make this document valid in court of law with the government approval, or whatever NMC, whatever you can do with your association to go ahead with the government and talk with them, to have these guidelines pertinent to 3-level setups, namely primary, secondary, tertiary, so which can be argued in the defense in the court of law. And the third, for the emergency and limited resource setting places, what minimum is required, what can be done, and which will be really helpful to the doctor of our fraternity when they fight a case in the court of law, when this document will be very important as a defense in the court of law. Hope so, you will consider my suggestion. 3 cases of MTP I will narrate, and these all 3 cases are real ones, which I am attached to it. And I know all these 3 cases where I was witness for that. Death on table while doing NTP, no anesthetist, FIR was done, mob was there, and for safety, doctor made to wait in police station. The another case where death happened after MTP procedure because of massive bleeding, it was unregistered center. FIR was lodged, immediately doctor was arrested in view of unregistered center and applying the section 304 instead of 304A. And the reasons are different for applying 304 because there was knowledge that his center was unregistered and even though he ventured in the MTP. The third one is that while starting the MTP procedure, the injection prostadine, which is massively used by an obstetrician gynecologist, given anaphylactic reaction occurring, there was frothing and pulmonary edema. It was treated, it was recognized immediately and treated promptly. It was shifted to the tertiary care, was on ventilator, came out from that. So here there was no litigation, but these 2 cases FIR was done. This is the important message which always is on the, I will just go to this 1 minute. So this is the message, the WhatsApp message which is circulated in the WhatsApp University, no FIR against advocate or doctor. It's not true. On FIR by patient, FIR, that is first information report, can be lodged by anyone across the country, the citizen of India and the police station against the one having allegation and grievances. So FIR can be lodged against doctor when the patient thinks of any medical negligence while taking the treatment. But no arrest as per so, because there are important case laws, Martin D'Souza case laws say not to arrest doctors, refer the case to the committee of doctors. Jacob Matthew case law says burden of proof is always on the complainant and there should be a standard of care to the reasonable degree of skill and knowledge. Suresh Gupta case law says that mere accident is not a gross negligence. The another important case law, which is Kusum Sarma Vatra case law, it laid down the principles for determining the medical negligence, and this was the WhatsApp circulation of the SC sets 11-point norm on medical negligence. This came from this case law, and this has to be applied by the police. So once FIR lodged, what happens? It's very important. I will speak mostly on the practical points. Once FIR is lodged, there's a police call or police arrives at the site. They do the Panchanama. And this is the only incidence where the original papers are seized by the police. You cannot give Xerox paper. Here you have to give the original papers. So best thing is always whenever you submit a papers, they give time. Don't worry. We have unnecessary fear of the police. They are also human beings. And when we are considerate, they also listen to us. Please complete the papers, number them properly, sign on each paper, and then hand over and just take the signature that original papers are given and plus use Xerox for your site. Or the police may send if it's a cold case, it may be send a written letter, someone. Then once this comes to us, we should be always, they ask for the statement and they make an inquiry, then refer to the committee of doctors, which may be civil surgeon or the district health officer in the districts, or in the cities, it will be medical colleges as JJ at Mumbai or Sasun Hospital, BJ Medical College at Pune. And if the committee feels prima facie of medical negligence, then only the case proceeds. So we should be very good. We should be very calm in that. To just say, whenever the police call comes or police asks to come, don't refuse. Talk nicely to complete the work is that complete the papers and documentation should be done properly. Preferable time to go to police station is always go in the morning, never in evening, never late evening, never in night. You can refuse going to the police station in view of our emergencies or the waiting patient. And whenever one goes to police station, always you take a good friend of yours or a good lawyer of yours. When before going to the police station, please understand what was the case. Just get the input from good medical legal expert. And the important thing is always you should inform the spouse. And because if you go to police station, we never know what will happen there. Your spouse should be always informed, and the reliable, good friend should be informed. Relax and to be calm. You should be always polite. आपल्याला असं डॉक्टर म्हणून आपलं सुपर ह्युमन वाटतं आणि आपलं इगोइझम वाटतं. We should never do that. We should be polite, humble. Please don't do any show off. मला हे माहिती आहे, ते माहिती आहे. Please don't do that. Reply to the point. And of course, whatever the questions and whatever they ask police, please reply to the point. Avoid answering ifs and buts. He झालं असतं, हे झालं असतं, हे केलं. Do avoid answering these ifs and buts. Read the statement before signing it. You can get edited, added, deleted, whatever you feel that is not written properly, you can do it. And just I am not saying this because I have gone through all these things. And one more important message I want to say to all the association, local doctor association, you should develop a rapport with the police official. We should have a courtesy meeting and to visit the police station as an association. So this is a thing, and believe me, you should never get tensed. I have seen the biggest consultant perspiring the code in the police station. Believe me, but really to say nothing happens, don't worry. This is the procedure, normal procedure. You should take it as a part and parcel of our practice. And this is going to happen. Don't worry. We have to but the back of the mind, the best thing is if your documents are right, if your documentation is right, don't worry, and it will take a course of time. Yes, I agree. There's a stress. There's nothing, but I think so. One should not worry about it. If report states prima facie of medical negligence, then what happens? Then everybody knows BNS has replaced Indian Penal Code. And this is just, I'm sharing two links which are very important. One can get whatever the section was in IPC, replacement for that BNS section. And this is the beautiful link where you can just click and get all the details of the 358 section of the BNS in the 11 languages one wants. So this is just why I have given this, because what is the BNS section of medical negligence? If prima facie says medical negligence, then this is the BNS 106 and the subsection 1 is the applied as a for medical negligence. Previously it was IPC 304A, and it is a still bailable, cognizable, non-compoundable. The only difference between for the first time, the medical negligence or the negligence by the medical practice has been defined in BNS, whereas in IPC it was not that. It was only causing the death of any person by doing any rash or negligent act. And there, the imprisonment, the punishment was imprisonment up to 2 years or with fine or with both. But in BNS, what happened? There's a punishment if it is by registered medical practitioner by performing medical procedure, the imprisonment will be 2 years and will be fined. So there's no clause of only fine, and therefore this is the BNS 1061 is applied for the medical negligence. The question is whether in view of the new BNS, the Supreme Court directives Jacob, Matthew, Martin, D'Souza case still holds true or not. So these are all the things, whatever the Martin Tissot case says and whatever the 11-point norms on medical, the answer is yes. So it is still valid in view of BNS 1061. So what are the criminal liabilities anesthesia practice under the medical termination of pregnancy revolves around the negligence and failure to adhere to the legal and medical standards set by the acts. So I will just narrate a key point because the time is a constraint. The negligence, if their actions or omissions during a procedure lead to serious harm or death, duty of care, anesthesiologist has a legal duty to provide care that is established by medical standards. Breach of this duty, informed consent, already consent has been spoken. So informed consent, proper consent, compliance with the MTP Act. The MTP Act outlines specific conditions under which the MTP can be done, and anesthesiologist must ensure that their role in the procedure complies with these legal requirements. And of course, documentation, I will not speak more because document is the backbone of any practice medical fraternity in this era of consumerism. The another thing, what is the role of anesthetist in medical termination of pregnancy procedure for ensuring patient safety and comfort? So there are the key responsibility duties are pre-procedure assessment should be done, not in haste or hurry. One should give time, that is important, and administering anesthesia, proper dose, type of dose. Monitoring patient during procedure is very important, and pain management as well as post-procedure care. And we have seen what are the case laws which has been said by Dr. Kumbar sir as well as by Dr. Pratibha Kane, all related to this death on the table, everything related to the drugs, not monitoring and just left in the post-recovery room. And these things are there, and documentation this last. And the most important is this, the medical termination of pregnancy outlines the legal framework terminating pregnancy in India, and anesthetists play a vital role in ensuring safe and effective procedure. So how the acts relate to anesthetists? Legal compliance. Anesthetists must ensure that their involvement in MTB procedure adheres to the provision of Act, including conditions under which termination is permitted. असं बोलून चालणार नाही की आम्हाला नाही माहित तर बघून घेईल ऑब्स्टेट्रिक गायनेकोलॉजिस्ट बघून घेईल. That's not the case. You should also see whether it is done properly or not. Medical expertise. The Act requires MT procedure to be performed by qualified medical practitioners, and the patient safety is important. Confidentiality is the most important point in the MTP Act, where the Act emphasizes the protection of the patient privacy. Anesthetists must maintain the confidentiality regarding the process of the patient medical information. And last, the documentation, which is always the backbone. So I will not highlight that. These things are the important way to the medical. So this is a Form A, which is applied for the approval of the center. And Form B, which says what is the certificate of approval. Anesthetists, wherever visiting any nursing home, any hospital, they should see this, that this certificate of approval is there or not for that center. Just ignoring this will cause a problem. So this is the certificate of approval. And third, which is the consent. It is very important. And this consent, when the patient is above 18 years and below 18 years, this to be looked after anesthesiologists also. This is your job also. And one should see these things. And Form A, Form B is because there's a composite negligence if any case gets. So I will just come to after that. But what are the this of punishment? Up to 2 years, which may extend to 7 years if the person is not a registered medical practitioner. And if that is not terminates in a place other than mentioned as in section, again the not less than 2 years, and which may be extended to 7 years. And when the privacy shall not reveal the name and other particulars of woman whose pregnancy has been terminated, except to a person, and if nothing is there, so anyone contravenes this punishment is up to 1 year or with fine or with both. So these are the punishments of the MTP Act. So we should be very careful. And as an anesthesiologist, we should always keep all the records with us. And the most important, whatever the points you write, whatever the notes you write, it should be in the proper indoor paper. It should be in the continuity of whatever the indoor paper. It should not be on the separate paper. Otherwise, it is misused sometimes. And court of law doesn't believe the free paper or the extra paper which is attached. So it should be in continuity, it should be in the numbering, and it should coincide with the findings of yours as well as the surgeon or the gynecologist, whatever is there, and it should also corroborate whatever the incident is there. As an anesthetist, you always try to maintain water. And please don't do the blame game. This was not my job. This was job of that. It's a teamwork. And when is the team? But as an individual, one has to save one's own skill. One should write the notes properly as per the role of the anesthetist. And there's 2 or 3 things which I want to say is the termination of medical termination of pregnancy under the age of 18, as well as these 2 things, survivors of sexual assault or rape or incest and minor, means teenage pregnancy. Probably this may attract the POXO Act, and therefore this is a mandatory reporting under POXO Act. Section 19 says any person who believes this is happening, so it has to be reported to the police or the Special Juvenile Police Unit or the Child Welfare Committee. And punishment, if not reported, is the Section 21 of the POXO, which says up to punishment up to 6 months for an individual. And as a hospital, the corporate or the hospital, in company or institution, it will be 1 year for a person. But it's a very challenging to mandatory reporting. The another option way out for that is always report this case to Child Online 1098. So you are informing, at the same time you are getting these things done. So just a few more slides regarding essential of negligence. I think so everybody knows, but one should always keep on narrating these things once again and again. Once there's a duty towards patient by anesthesiologist, when is there any deficient duty which directly results in the damages, physical, mental, or financial to patient relative, is the essential negligence. 1 or 2 words regarding burden of proof. Whenever these incidents happen, burden of proof is always on complainant, and criminality, it is to be proved beyond doubt, and sometimes burden of proof shifts to the defendant. The terminology is res ipsa loquitur, where things speaks for itself. And in related to anesthesia, where a patient developed massive tissue emphysema due to wrong placement of needle for jet ventilation of the lungs, this is a thing speaks for itself. Where explosion occurred during the course of administering anesthetic to the patient and surgical mop left in the abdomen during helicis. These are things speaks for itself. And this type of negligence, which is anesthetist gets involved, is the composite negligence. This is an interesting case. Harm contributed by 2 or more. Gujarat State Commission in the Aruna Ben Kothari versus Navdeep Clinic. In this case, some orthopedic surgery was done on the forearm, and anesthetist, cardiologist, and orthopedic surgeons were involved. And because the death occurred, none of them can explain how it happened. It was under the, as said by Dr. Kumbar sir, the operation was done in the among the OT, which is the closed 4 walls. So liability, and the decision was given orthopedic surgeon 30%, anesthetic 60%, cardiologist 10%. The cardiologist on the table. Then this is the vicarious liability, where hospital authority vicarious liable for negligence of its employed personnel. And what it means for vicarious liability for anesthesiologist. Anesthesiologist may also be liable for mistakes made by their team members, means nurses, junior doctors, under the concept of vicarious liability, especially if they are responsible for supervision. Hospital can be held vicariously liable for the action of the employed anesthesiologist. Common allegation, just to go through the line: wrong doses of anesthesia, failure to monitor vital signs, delay in recognized complications, failure to manage allergic reaction. Allergic reaction management is very important. One has to recognize and do the equipment failure, example, ventilator monitors, failure to resuscitate during emergencies. And special legal situation anesthesia, I want to state, if there is in emergency, anesthesiologist may proceed without detailed consent if delay would harm the patient. But such action must be in a good faith and the patient's best interest, number 1. Number 2, anesthesia and pediatrics, extra caution needed. Courts impose a higher standard of care when minors are involved. And one more thing I would like to say, most of the time hospitals ask for the pediatric fitness from pediatrician. It's always best to have the pediatrician of your center, of the pediatrician which is nearby, across the road. If anything happens, he should come immediately. Taking the consent of the pediatrician from the remote place doesn't work in this case. So that should take care. High risk patient, document all risk clearly, obtain detailed consent. Courts recognize that high risk cases require special documentation monitoring. So that good faith, many times in court of law, we don't make use, our medical fraternity don't make use of the sections which are related to the good faith. I will not go in the detail, but just to sensitize you all people, BNS sections related to good faith. In details, I will not speak on this because it will take time. It's a time constraint. What the bottom line I want to say is that sections 2, 11, 18, 19, 25, 26, 27, 28, 30, 31, BN section is all related to good faith, with consent, without consent, causing less harm, and communication done in good faith. But At the same time, the good faith should be documented. हम लोग आपण काही बोलून असं निघू शकत नाही की बाबा गुड फेथ मध्ये केला. That good faith has to be documented, and in emergency, it's essential of intervention without consent has to be documented, and that should convince the court. So this is the related to good faith. Some 2 or 3 sections which are very important. We have the habit. When something happens, we always fabricate papers. We never do fabrication of paper. Don't fabricating false evidence. Section BNS 228 applies. Signing false certificate 230 applies, and 1. And making a false document is 335, and 238 is the causing disappearance of evidence of offense or giving false information to screen offender, and 239 is important thing, intentional omission to give information of offense by person bound to inform. So these are all related to fitness certificate, medical certificate, and related to false fabrication. So papers, we should learn documentation. That is the basic line. And if you are writing, you just make a line on the thing and you can change, but don't erase completely, and use the same pen, use the same ink, use the same handwriting. Don't do the overwriting, and don't do this. It is a lecture itself on the how to write the papers. And then this I will just skip, this nothing. So at the end, I would like to say prevention is always better than cure. And one more word about arrest. Arrest, because I have not kept any slide on arrest. Regarding arrest, see, whenever this BNS section 1061 is applied, there is no arrest and it cannot be arrested unless and until prima facie of negligence, then the case proceeds. And the arrest can be done in the cases where something serious is happening, other sections are applied, where it is there only it can happen. Otherwise, almost nothing happens. And believe me, all these cases go for 10 to 15 years, and we have to just face and just is a part and parcel and just to bear with it. And the end, I would like to say, if we believe these 6 words, we should learn as an anticipation. Anticipation is a word where, as an anesthesiologist, when you practice, you are going to give the anesthesia, you should anticipate what wrong can go. And for that wrong, what thing is there. There are so many cases, because I have not taken the case law, but there are the case laws which are related to anesthesia without infrastructure. There's overdoses of spinal anesthesia, hypoxia on OT table, cardiac arrest on OT table. These are all related to the availability of oxygen, availability of equipments failure, all these. So these things to be anticipated well in advance. Documentation already, the word is justified, informed, and the communication, we should learn to how to communicate, and whatever the communication we do with the patient, it has to be documented in the high risk patient. You should always document what are the risks involved and what are the things they should have understood in their language, read 1 or 2 lines from their side, written on the paper, that मला जे काही समजलं माझ्या भाषेत सांगितलं गेलं आणि त्यांच्या हाताने लिहून घ्या, त्यांच्या भाषेत लिहून घ्या, आणि त्यांची सही आणि आपली सही दोघांची सही पाहिजे तिथे. इन लिमिटेशन, सी प्लीज restrict to the limitation. We should look for the our practice of our qualification, infrastructure, ability, and capacity. And always I believe we should try to follow the principle ethics. May not be 100%, at least majority 75-80%. 4 principles of ethics: respect, do good, do no harm, equality. And at the end of the day, whenever we are doing any work, as a practicing, we should always think that if this patient would have been my near and dear ones, what would I have done? And we should always give the option, respect the thing. But whatever you say, whatever you feel, it has to be documented on the paper. With that, I stop my presentation and I stop sharing. Thank you very much.
Thank you, sir. Thanks a lot for a lot of inputs, and also for going through our book, and your suggestions are most welcome. We will definitely think of taking it in the next meeting. Thank you, sir. Thanks a lot.
Thank
We're
you.
running behind schedule a little, but thanks a lot, sir, for a very good description. Coming to the next speaker, Dr. Rajiv Joshi. He's another pediatrician, a geneticist, and a medical legal consultant of great repute. He's the founder of the Medicolegal Society of India, trained in various medical informatics such as SNOMED, CT, HL7 fundamentals, artificial intelligence. This was way back in 2010. Statistics, advanced database. He's the only doctor from India selected for fellowship in biomedical informatics in the USA. Also a fellow in biomedical informatics and observer in medical genetics. He's been associated with the Maharashtra University of Health Sciences, High-Tech Medical Info Services Private Limited, and developed a portal, that is the aryamitra.com, for networking blood donations made easy in the country. He has also developed the Mediwind portal for doctors, hospitals, and clinics. Also, he has a portal of patienteverywhere.com. He has filed many criminal public interest litigations for prevention of violence against doctors and other social issues facing our profession. It is extremely a proud privilege for all of us to present a real medical legal social worker, I would say, Dr. Rajiv Joshi. Over to you, Dr. Rajiv Joshi, sir. So you can start, sir.
Thank you very much, Dr. Pankaj Gupta, for your kind introduction, and thank you, ISA, for inviting me here for giving this presentation. I especially thank Dr. Pratibha Kane, Madam, for introducing me to the ISA as well as helping me in medical tasks of Medical Legal Society with great determination. So today, the topic that has been given to me is legal avenues for justice on facing violence and abusive relatives. And I am showing you the two slides or two pictures of the goddess of justice. The earlier one was blindfolded with sword in hand, and today the new goddess is having constitution in hand and eyes are open. And our Chief Justice of India said that now our understanding of the justice has to change. But I have serious doubt whether justice has changed for doctors in last few years. And therefore, I would like to just first present the data of violence against doctors from 2016 to 2021. It is presented by Maharashtra State Government in High Court of Bombay, in which there were 636 attacks and 1,381 accused, out of which 36 cases were decided and only 4 were convicted. So this is the percentage of justice that doctors are getting from the courts of law, and we'll come to that why it is happening so. So for this particular reason and for many other reasons related to doctors and medical professionals, we formed Medical Legal Society of India, and Dr. Kane was one of the first few to become the pioneering members of the association. MLSI takes up issues of doctors, medical legal interests of doctors and patients, as well as it files appropriate petitions to the High Court and Honorable Supreme Court of India. It trains medical and legal professional certificate program in law and medical profession. 200 plus doctors have completed 13-week program, and 750 plus doctors attended individual sessions to avail one CME credit point. So this association has been working literally, very diligently to protect interests of the doctors. And now I start with my presentation with respect to the topic under consideration, that is our legal avenues for justice on facing violent abusive relatives. What are you supposed to do? On facing abusive and violent relatives, doctors must file police complaint. Doctors must file police complaint. If you don't file police complaint, nothing will happen. Police is not going to come to you and ask you, whether doctor, are you beaten? Your hospital is broken? No. You have to go there and you have to file police complaint. It is your duty, or anybody who is aware of this. Suppose you are beaten and you are, in coma because of head injury. The hospital owners, your friends, anybody who is aware of the violence has to go and make report to the police with names of the patients, their relatives, offenders, unknown persons who trespassed into your premises. So while filing police complaint, the victim must inform the police all the details of the episode, followed by evidence such as audio-video recording, photographs, etc. Abusive words used. What words were used, you have to write or you have to tell them, amounting to intimidation, because intimidation is an offense. Physical violence against doctors and staff members, and damage to property with approximate valuation. How much is your loss? We'll come to know why it is so in the next few slides. then a FIR has to be filed. FIR is first information report. It is the report of information received by police station, and on receiving the complaint, police will decide whether to file non-cognizable offense or to file complaint under section of cognizable offense, usually under previously IPC 1860 or currently now BNS 2023, as they don't know special acts. Remember my word, police don't know special acts of your state. You have to, therefore, take the copy of Medicare Service Persons and Protections Act in your state to the police station and show them the sections pertaining to violence. In all state acts, the offense is cognizable and non-bailable, except in West Bengal. And I say that with authority because when I filed a public interest litigation in Bombay High Court, we have submitted a comparative chart of 21 state acts with Bihar rules, Epidemic Disease Act, and we have suggested guidelines, which is in the last column. So guidelines you'll see all here, yes, but some acts have some provisions and other acts have some don't have some provisions. I will not go into details of each provision, but you can see here that the nurses, paramedical persons, medical students, nursing students are there in most of the acts, but auxiliary nurse midwife, health visitor are in some acts and not in some acts. Ancillary support staff is there in some acts, not in some acts, and other establishments like clinics are not in many acts, so that we have tried to cover them in what we are asking from the Bombay High Court. Then there are provisions of cognizable at number 21 in most of the acts except for West Bengal, and the provisions for bailable or not bailable are there, not bailable in most of the acts except for West Bengal. So please understand that in all the acts, the offense is cognizable and non-bailable, which means the patient will have to be arrested and then, if the court deems it fit, released on bail. So there are so many provisions, but we'll just go into the definitions of act. What is violence? Violence means an act which causes or may cause any harm, injury, or endangering the life, or intimidation. Remember this word, intimidation. So if you tell them that the words used amount to intimidation, then the person can be booked under the violence. Obstruction or hindrance to any Medicare service person in discharging his duty in a Medicare service institution or causing damage or loss to the property in a Medicare service institution. So all these are cognizable offenses. Now, prohibition of offenses. Any act of violence against Medicare service person or damage or loss to the property in the Medicare service shall be prohibited. That means mandatorily it will be prohibited. And then penalty. Any offender who commits an attempt to commit or abets or incites the commission of any act of violence in contravention of the provision section 3 shall be punished with imprisonment, which may extend to 3 years, with fine, which may extend to 50,000 rupees. This is Maharashtra Act. Now we go to what is the liability to pay compensation for loss or damage to the property. You can see in the diagram that there is a damage to property, and in this case, in addition to punishments in section 4, offender shall be liable to pay compensation of twice the amount of damage or loss caused to the property as may be determined by the court referred to in section 5. And if the offender has not paid the compensation imposed under subsection 1, the same sum shall be recovered as if it were an area of land revenue. His property will be confiscated, sold, and your amount should be paid, provided you follow up the case and take it to its conclusion. Now, I'll bring you to this Kerala Act, which was promulgated after unfortunate death of this young girl in Kerala. A young doctor was stabbed for 13 times in chest, and after her death, the Kerala government promulgated ordinance and converted into the act after MLS intervened in this matter. And there, the ambit of act was increased to paramedical workers and administrative staff in hospitals. They provided for faster investigations to be done not below the rank of police inspector, to be completed within 60 days from FIR, expeditious trial, special court and prosecutor to be completed within 1 year, telling which reasons in writing to be given, and graded punishment was added. Mind this, verbal abuse, punishment up to 30 days and up to 10,000, physical violence, punishment increased from 6 months to 5 years, and 50,000 to 2 lakhs, grievous hurt, punishment increased from 1 to 5 years, and 1 year to 5 years, and from 1 lakh to 5 lakhs, and damage to property twice the loss sustained. So this is very important development in Kerala in September 23, after which Karnataka Law Commission had recommended amendments in the Karnataka Act in its report number 46, and in July 24, after MLSI requested the Karnataka government, the Karnataka state has changed its act to be the best act in the country, in which there is a provision of intentional insult, which means use of words, figures, or gestures with an intention to insult, humiliate, disgrace, or annoy or abuse a Medicare service person, either directly or addressed to him, or through social media, or through unauthorized audio and video recording and photographing in connection with his professional duty. Therefore, this intentional insult has become a cognizable offense in Karnataka, not in Maharashtra, not in Kerala, nowhere else in India, but in Karnataka it is there, because thanks to Karnataka Law Commission report. The employees working in the medical service institutions, including security guards, managerial staff, ambulance drivers, and helpers, and prohibition of intentional insult. Any intentional insult of medical service persons in the medical service institutions has to be prohibited, and the court shall, most important clause to me, court shall, while trying the offender under this act, not insist for corroboration of the evidence of victim or manager or owner of the medical service institutions, as the case may be, while holding the accused guilty of the offense, unless it seems valid reason to record in writing for corroboration. This means they will not ask you to prove that there was violence and to prove that you were offended. They will understand that a doctor is coming in complaint. That means there has to be some offense. Now, proceeding further, what we really need to protect doctors, what we are asking from High Court and Supreme Court of India, Epidemic Disease Act 1897, amended in 2020, had two important clauses, and we are asking these two clauses should be included in the acts. Presumption as to certain offenses. Wherever there is an offense prosecuted for committing an offense punishable under subsection 3, the court shall presume that such person has committed such offense unless the contrary is proved. Presence of culpable mental state. In any prosecution for offense under subsection 3 of section 3, which requires a culpable mental state on part of the accused, the court shall presume the existence of such mental state, but it shall be a defense for the accused to prove that he had no such mental state with respect to the act charged as an offense in that provision. So remember that somebody coming into the hospital and beating a doctor, there is a presumption as to offense as well as presumption to culpable mental state, which will take him to the jail, no doubt, but these provisions are required in regular acts and not in Epidemic Disease Act. That is what we are fighting for. So what are the shortcomings in all state acts? There is no provision for repeat offender, no provision for frivolous complaint, administrative staff, paramedical workers, non-medical workers, supportive agencies, attendance of the patient, vehicles, medical records, etc. Now, Dr. Khan has told you the importance of medical records, but there was an incident in Nagpur where the patient's relative burned the OPD and burned all the medical records in the hospital. So very important shortcoming that we have to bring to the notice of the government and to the courts. Now, going ahead, I'll just go through these sections. I will not read them, but so many things are not there in so many acts. So we want them in the model act that were requested from the High Court and Supreme Court. And we want deposit before bail, which is a difficult task, but that is what we are trying to get in these acts. So what is first information report? I have told you. Important thing is that insist that appropriate sections from special act for violence must be included in the FIR. This is a sample of FIR in which initially you can see here that only BNS sections were, or Bharatiya Dandavidhan IPC sections were written. We have gone ahead and told the police that you add this Medical Professionals Act, which is a special act, and this addendum has been done after our following up with the police. This can be done, this has to be done, and if the police is not willing to do that, you have to obtain copy of FIR, which is your right. If police do not file FIR, then obtain copy of non-cognizable offense, or if police do not include appropriate sections from special act, then give them a letter requesting to file FIR and or add sections and send copy of that letter to Commissioner or Superintendent of Police. This is very important because if sections are not there in the FIR, it will be difficult to get them into the trial. Usually police know the accused. Remember this, police are hand in glove with the people who are perpetrator of injustice against the doctors. They know the accused, hence they may avoid to take complaint or file non-cognizable offense or not file FIR under appropriate sections. They just file faltu simple IPC sections and the accused will go away. File sections of special act for doctors. In case your complaint is not handled well by the police or higher authorities, you can file complaint directly to the magistrate under 156(3) of CRPC or 175(4) or BNSS. This is what is your next step. You must do that. Don't say that I filed FIR, things will be all right. If they are not doing anything on your case, go ahead and file with the magistrate. Now, next slide. Section 156(3) of the Code of Criminal Procedure empowers magistrate to order an investigation by police officer upon receiving a private complaint, even if police doesn't hasn't taken cognizance of the case. And in Bharatiya Nagarik Suraksha Samhita, the change is that modification is that procedure requiring magistrate to conduct an inquiry into the complaint and consider submissions from the police before ordering an investigation. So they will invite police and ask them their explanation, then order them to investigate further. But still, you can go to the magistrate, that is for sure. So, what is the method of information under section 154 and 150 or 173 and 174? It is oral complaint filed to the police, which they are supposed to reduce in writing. Police officer will record the entire incident in writing and will narrate that written information to the informant. Informant suggests any corrections in it, then police officer has to make corrections in it accordingly. Then when informant says that entire narration is correct, the police officer has to take signature of the informant, has to give receipt of such information forward duplicate copy along with signature, stamp, date and time of receipt. And this written record is important record for the court proceedings. Subsequently, after entire incident, police has to decide whether the offense is committed or not. If the offense is not committed as per police, they will give you informant in writing that offense was not committed. If the offense is committed, then they decide civil or criminal. Offense is civil in type, they have to advise you to go to civil court. Offense is criminal in type, the police officer has to decide whether the cognizable or non-cognizable. If the offense is cognizable, police has to register FIR. If police refuses to register FIR, informant can approach the Commissioner of Police or Superintendent of Police, as I told you before. If CP or SP refuses, an informant can approach JMFC under section 2 through 3. Accused needs to be heard by the JMFC, and then the proceedings will follow. If it is non-cognizable, then police has to record in special register, and then offense of defamation, etc., will not be registered as a cognizable offense. Once the cognizable offense is registered, they will decide whether it is bailable or non-bailable. If it is non-bailable, then police will arrest him, and then the accused will have to get bail from the court. If it is bailable, police will release him on get bail. Now, in this diagram, I am showing a non-bailable offense in which court granted bail to a person who beat up a doctor after sibling's death. And उधर what happened was, तो मेरा भाई मर गया, मेरा ये हो गया, मेरी माँ मर गई, सर मैं झमेल में आ गया, सर मैंने डॉक्टर को झपाटा दे दिया, मैंने डॉक्टर को मार दिया. So on the spur of moment, I have done something. If that is a statement made by the advocate of the accused, the magistrate is likely to relieve him on good behavior bond. So important thing is, don't get into IPC. You have to file FIR under specific sections of Doctors Protection Act. I'll stop here and then we can go for question answer, because I got so many things to tell about the previous speakers also, but I will go it step by step. Thank you so much, and we'll proceed for next session. I hope I have completed in time.
Yes, sir. Thank you, sir. Thank you, Dr. Joshi, sir, for giving a lot of information in a short time. I know these topics are actually, each of you could have talked for an hour, but then we had to restrict also all the audience. We'll go to there are a lot of questions in the chat box. And the first question is towards Kane madam. Should we start videography of operation by keeping a camera in OT light?
You can take operation and any digital format that you have. How are you securing it? And is the patient's, it is patient data. Okay, whatever is surgery is happening or whatever interesting thing that you want to capture is patient data. So who takes it and how you take is really not important. What is more important is what you do with it. And can it be shared or is it being shared? And is somebody, see, when I gave that example of that cesarean section photograph, I mean, he must have just said, okay, this is something so interesting. And we keep sharing on social media. So we have to be very, very careful, very careful. Now, how the patient's relative came to know about these pictures, we really don't know. I mean, how much it may happen just once in a while. It may not really happen, very often. But now we are like, we have to be a little cagey about the data that we are collecting. We are creators of that data. We have to keep it secure. How you take it, for what you take it, and it has to be for lawful means, of course.
But I'm reminded of a case, madam, where I feel the obstetrician's son who was in the school, there was a photograph of him operating on the patient,
Oh,
and it
yes,
was
yes,
socially
yes, yes.
circulated in a very big way.
Yeah,
And obviously, the case, there was a case filed that how can a
child.
unqualified person, child, do it?
No,
So
no.
that sort
So
of
we
thing.
don't know. We are, we are not aware. See, the whole question is about awareness
Awareness.
that this is patient data. And like I said, they are crown jewels. You don't know, you just keep them secure. That's all.
Yeah. Madam, next question to you is, can hospitals sell patients' data to software companies?
If they have, see, AI also is being developed with unethical use of this kind of hospital data. Patients don't know it, nobody knows it, and it is a very big ethical problem that hospitals are selling and everything. But legally, no. They have to inform every patient that, do you have any objection if if your data is released to this pharma company? So they ideally you have to take specific consent from every patient. But now you have seen so much of research which is getting retracted. That is because there is no consent. There are so many research projects. Now we are taking we are doing research. Every resident of ours has to actually take a consent that you are taking part in this kind of clinical trial or whatever. So consent is very, very important. Consent, there is now going to be consent managers, official consent managers. So the patient can say, yeah, you can release it to this person, but not release it to that.
Thank you. Thank you, madam.
I
Dr.
will add
Kumar.
just one point on this.
Yeah.
One
Yes, sir.
service provider of telemedicine called me one day and he said that XYZ doctor was giving ABC treatment to LMN patient. So what do you think? Is it correct? So I asked him, how do you get this information? So he said, I am a service provider and I got all the data. So I said, that means you're doing something very illegal. He was not able to accept this. So this is the situation in India. That I think that makes a point. Thank you so much.
Yeah. Dr. Kumar, the moment we inform death on table, chances of relatives becoming rowdy are there. So shouldn't we be informing the police just to save our own skin before declaring DOT?
Definitely,
Yes.
definitely, sir.
Yes.
Every patient relative, you have to see it in a litigant angle. If a suspecting the mob is because looking at the body language of the relative, probably you can come to know it. But this is quite evident that the relatives are coming in a mob, and probably there's nothing wrong in calling 1001 to safeguard yourself and the hospital staff by informing the police.
So I want to make one point here, and for which I want to show a slide.
Yeah.
Which is one of my very favorite slides. I hope you can see it.
Yes, sir.
And this is a picture everybody can relate. वो 70 मिनट आपके जिंदगी में से कोई निकल के नहीं लेने वाला है. That is what Shah Rukh Khan tells these girls of Indian hockey team. replace Shahrukh Khan with Rajiv Joshi and all of you doctors. वो 90 मिनट्स आपके जिंदगी में से कोई निकल के नहीं लेके जाने वाला है. From the time of any event in hospital to declaration of death of a patient, use those 90 minutes for CPR. At the same time, completion of documents and inform police. Inform police only to save yourself from violence, because a person in uniform will be able to save you more than any amount of doctors or friends coming there. The first thing is inform police. There is some different opinion that it is not necessary to inform police. I have fully respect that opinion. But from the violence perspective, inform police, get one cop into the field. But before that cops come in, your paper should be complete, number, xerox, and hand over copy to that police, because the cop is going to confiscate your paper. So 190 minutes, you have to first complete your paper. Doesn't matter if you inform the police after 30 minutes or 60 minutes or 90 minutes, save your skin first, because after that there will be long, torturous legal processing where you will have to defend yourself. Those 20, 15, 30 minutes are not going to be much of a doubt or much of a problem. If you record properly, show it to some senior anesthetist or some senior surgeon, get it weighted. If there are minor errors, remove them there and there itself. The Harvard Medical School says that every 5 minutes anesthetist has to make a record. And your machines are able to produce that kind of record. But hardly any case is there in court wherein doctors have recorded their information after 30 minutes interval. The court says what we're doing for 30 minutes, you're not seeing the patient. So please record at least after the event, every 5 minutes, 11:05, 11:10, 11:15, 11:20, by hand, record something or print out from your monitor and sign that that is an authentic record. Thank you so much.
Should I say
Thank you, sir.
something? Should I say something?
Yeah, please, sir, please.
Practically, I feel any death on the table should be reported to police. It's always better to be on the safer side, one thing. And I always say, if something happens now, I always, before declaring death, always inform the police, have them make the all documents properly, just as sir said, what those 30 minutes. You should not be waiting, but write what those 30 minutes you are doing, document properly. And what Dr. Kumar sir said, I respect his view, but this happens only if the patients are comfortable that this may happen. You are able to convince. But usually the patient who goes in surgery, OT, goes well and comes when death is there, always is a shocking news for the relatives. So it's always best.
Correct.
And let the relatives then decide. One of the incidents I remember that happened at Pune only, when the death happened of the celebrity. But they give all the in writing that we are not going to do this, we are not going to do that, and then only the death was declared. So it's always to be on safer side, that I feel.
Yeah, one more thing, sir. No, even if the monitoring is every 5 minutes, okay, the anesthetist has to be vigilant to observe it. In one of the cases, the court has clearly said that, see, anesthetist was on his iPad, okay, and they were sending emails and Facebook and other things. So, low-risk patient, when he had a cardiac arrest, they retrieved the monitoring. Even the 5 minutes there was a record, anesthetist was not looking at that. So, the court categorically said it, treat it or tweet it. Okay, so that way he is held responsible, not looking into the monitors, even though observation was monitored for every 5 minutes. So I think we should restrict using the mobile phones in the operation theatre, sir. When the patient is comfortable, everybody uses the mobile phones in the OT. I think we should stop entering into the OT. Whether it's a minor case or medical, stop taking your mobiles into the OT or ICU.
It's a dangerous thing. The first thing they do, the police will take away your mobile phone.
Yes,
You can get so much evidence from that only.
And
that's enough. That is enough. How you are monitoring the patient.
And to add one interesting line, whenever things happen, they always doctors talk on mobile. Never talk on mobile. If you want to ask anyone what to do, ask on the landline. Because this mobile phone taken, then everything goes. What you're asking and what sources of information. Yes.
Very good take-home messages are on mobile. Use of mobile in the OT. All of us will definitely keep all these points in mind. The next question is to Dr. Hemant. If surgeon has given spinal, whose responsibility if some mishap happens?
Already, I think so Dr. Kumar sir has answered that, but definitely he will be responsible. And in this era of those days are gone where surgeon used to give spinal. Now surgeon should not give, and this is a era where there is a cross specialty practice should be avoided. And the famous case law is Prashant Dananka versus Nizam Institute of Case Law. So we should avoid. So in this case, definitely he will be liable.
Yeah, he is criminally liable. Yeah.
Sir, unfortunately, in our country, in some of the peripheries,
Yes. Now
these things still have happened in the last few years back.
Yes, sir. There is one catch in that cost specialty practice. If you are located in such an area where there is no anesthetist available and it's a life-saving procedure for that patient, surgeon can give spinal. That is the catch in that. So that can always be defended.
Yeah,
but then this will not help you in the cold cases. In the cold cases where you have time, you should not go into that. You should refer at the right center for the anesthetist. But in emergency, even surgeon can give spinal if he feels the life-saving procedure for the patient.
Yeah, and also you should bring to the notice of the patient relatives. Okay,
that it is
and
an
if they opt for
emergency.
that.
Right. So does anesthesiologist carry vicarious liability for forgotten pad inside abdomen?
I have already replied in the chat box, but still I want to just narrate it. In the case of forgotten surgical pad inside a patient's abdomen, the primary liability would typically fall on the surgical team, particularly the surgeon, assisting staff, responsible for ensuring all surgical materials are accounted for. However, an anesthesiologist could be implicated if their actions or omissions contributed to the negligence, such as failing to properly monitor the procedure or alert the team to potential error. And after all, it all depends on the discretion of the court as per the statements and the chronology of the event submitted in the court of law, which is watched for.
He is a part of the team.
He is a part of the team.
Because we have a case from Mumbai actually, not very long ago. Patient was a doctor, and she has actually said that the whole team, she has made anesthetists criminally liable, and she has said that y'all did not protect me. You know, y'all were the whole team connived to, though, you know, she had to have another surgery, but she has brought that criminal case against the anesthetist also.
Many times anesthetist while surgery is getting over, we tell the nursing staff or surgeon, count the maps, count the instruments, okay, to be more vigilant. Many times surgeons may take it very casually, but we insist, okay, count the maps.
What Dr. Ganguly has said is very correct. You don't know what the court is going to think.
Yes.
You really don't know.
Yeah.
Okay. Does not Jacob Matthews case mandate that FIR can be registered only after the opinion of a medical board?
No.
Great.
Now, there are two different things I will clarify. Lalita Kumari judgment and Jacob Matthews judgment.
Yes.
Yeah.
Jacob Matthews says that there cannot be arrest before expert committee report. That is question of arrest. Lalita Kumari judgment says that there cannot be FIR before with preliminary inquiry. Now, whether preliminary inquiry in Lalita Kumari means expert committee report in Jacob Matthews is not yet clear, and we have asked Supreme Court for clarification, but unfortunately it has not yet come up. However, as of my understanding of criminal law today, the Lalita Kumari judgment has got several this section 120.6 has got medical negligence, then matrimonial disputes, then financial frauds, etc., etc., etc. For all of them, preliminary inquiry is required before filing FIR. This means medical negligence will not be singled out separately, and preliminary inquiry by the police is sufficient as of now, though we want it to be after the expert committee report. That is what we want. But as of now, it is Lalita Kumari. As per the preliminary inquiry, police has conducted its inquiry. They have asked people, they have shown that they have done the inquiry. Therefore, I just wanted to inform all of you that FIR cannot be filed before inquiry. Now, police can say that we have done the inquiry.
You know, just coming, in fact, today, I think every death is looking like a prima facie negligence.
Yes, but then police have said that we have done inquiry and we will file.
No, they come to the hospital and say death ho gayi kya, and somebody is complaining. To them, that is enough of an inquiry.
Yes, but generally nowadays, they are filing FIR after medical board report. Now, in current case in Pune, they have filed FIR after the expert committee report of Sassoon Hospital has come. First in favor of doctor, second against doctor. After that, they filed a FIR. This is what is happening generally. But if they file FIR, doesn't mean that you are criminal. Don't run away. You can always get a bail because 304A or 1061 is available. Please do not file any application for anticipatory bail. It will get rejected because it is a bailable offense. Then the media will say court refused to give him bail. The police will say the court has refused to give him bail. So therefore, don't apply for bail. Go to the police station and give your documents for bail and get police station bail at police station. If they refuse, go to the magistrate. You will 100% get a bail.
Sir, today, just on this, I think Dr. Gangulia, they are adding non-bailable sections in thing like 34, which was criminal conspiracy, and that is what that girl has used when she said that a mop was thing. So it was 34 plus
304.
So it became a non-bailable offense. So, which section is being applied is also very, very important.
Thank you. Thank you. One more question.
Just 2 or 3 lines to say. See, basically, FIR can be done, but they don't take the action because of the instructions from they don't take the actions. Nowadays, they don't take the action what sir has said. But FIR can be lodged. And one more thing, whenever they do this thing, they always decide the sections what to apply, and it depends on that. And basically now BNS is good in a way because what used to happen in IPC, instead of 304A, they used to apply 304, and that used to be problem. But now when BNS had really defined 106 subsection 1, which is really non-bailable offense, so arrest is almost not there. And FIR, if lodged also, they cannot take the action unless until the committee report comes. That is sure. So we should not get afraid of this. And sometimes some police station also do these things. They write a comment. They ask them to give the comment, but they don't enter and just give it them. They make the inquiry and then they make. But it depends on the type of the patient going to there and complaining. For satisfying, sometimes they take, but they don't take the action 100%. That is it.
Thank you, sir. A case of local anesthesia was done and patient shifted to ICU for observation. He had cardiac arrest and despite resuscitation, patient died. What is the responsibility of the anesthesiologist?
See, this is anything under the sun, in my opinion, can have a arrest. Okay, it may be local anesthesia, immediate or delayed, and in the ICU they give antibiotic or things. But the law expects, okay, whether in time the cardiac arrest was recognized. After recognizing, what best has been done to save the life of the patient. So it does not mean that all cardiac patients will be revived. If it is the case, none would have been died. Okay. So in this case, the law expects whether the monitoring was done properly, even the patient was in ICU, and whether in time it is recognized, and what action, immediate swift action or CPR measures, what they did it, that matters in the court of law rather than proving a negligence in the cardiac arrest. I think
I would just like to say one thing, that somewhere we have to release our responsibilities. So at that time, if your ICU person has taken over and there is a responsible, qualified, responsible doctor who has taken over, we have to shift responsibility. Yes, anybody can allege anything, but, the reason why we shift patients to the ICU is because we want a responsible person who is able to take care of cardiac arrest. Okay, in short. So if that cardiac arrest has happened 3 hours after we shifted the patient, that means there was some risk, and that risk has to be managed by the ICU person. Though, of course, there is no way that we will not get implicated. But what I'm saying is that it is important to prove that we are not responsible.
So to add what Madam said, the document is the word one thing. One hospital should decide the policy. What should be the recovery time to be watched by the anesthetist? And what is the time which has to be watched? And after that, the time of the recovery under the observation of anesthetist, it should be defined. Maybe by each nursing home, whatever they decide as per the case, gravity of the case. And then you should be properly hand over with all the details written on the paper to the person who is the in charge of the ICU. That is
And in fact, I also
they will be implicated. But when in court of law, it has to be defended that way properly.
And I am so particular that when we are going to the ICU, I even kind of say that now the ICU people are responsible, because it is very, very difficult. In fact, the consultant in charge, I say yes. So I'm leaving, and all the decisions are going to be taken by the ICU personnel.
Can anesthetists who are present in this group can decide for sure that after local anesthesia or after spinal anesthesia or after general anesthesia for surgery for 2 hours, 4 hours, 5 hours, what is the exact time after which you can shift the responsibility? And can you come out with a consensus document? I have serious doubts whether you can, but you are the expert.
No, we
can't.
cannot come out
We
because
can't.
every case is different. And why we shift to ICU, the reason why we shift to ICU is for better monitoring. And like I said, that they should be able to treat whatever thing. The anesthetist's responsibility, actually, I know, doesn't really end, because even after 10 years, there are surgeons who say you got a spinal anesthesia and that's why you're getting backache. So the anesthetist's responsibility or allegations against anesthetists cannot end, means they are endless. But you have to hand over, and the handover document is important. There's so many times we hand over a patient on ventilator. So at that time we don't know where exactly how long that ventilator will go on over. It has to be explained to the relatives, and it has to be said that, okay, from now on, because the ICU people do not like us to go and say when to extubate. So it is actually, it's like a domain war. But yeah, we can, kind of put in inputs. But like every ABG, we cannot be involved in, so they are experts and we have to hand over to experts. And I think that I'm not saying it ever saves anybody, but it is a correct thing to do.
A related question to this: is it okay to declare death on operation table, or shift the patient to the ICU and then declare?
Policy. There has to be a policy. If there is no cardiac rhythm, you cannot take the patient out of the building. We have a policy that we will declare in the ICU, because it just gives us a little bit of time and we can keep talking to the relatives till then. But it is from a separate lift which the relatives cannot access, because nowadays the relatives have started looking at the monitors. So there's a flat line on the monitor. There are two judgments where there's a flat line on the monitor and they have said you are ventilating the patient. There is also a judgment that you're ventilating the patient for 3 days without cardiac rhythm. So all these things now, because everything is on social media, people are taking photographs, they're recording what you are saying. So wherever, if there is a death and no cardiac rhythm, if there is a cardiac rhythm, you can do it. You can, say that, okay, we have taken it to the higher center. But death during transfer is also a very, very difficult and dangerous proposition.
Dr. Pankaj,
Yes, Viren.
one question. Yeah, actually related to this local. Invariably, what happens is that a patient who is sick, who has a very low ejection fraction or sometimes something like that, the surgeon says, okay, I'll try to do it in local. That is a very common scenario. And what happens is, he says, okay, you remain here as a standby, so that if something happens, you can help. Now, the problem in this case, what I can judge is, after this discussion, is that he may be giving local, he may be doing surgery. If nothing happens, it's fine. But if you are on a standby,
I think your responsibility doesn't go away because you
No,
are the
it doesn't.
anesthesiologist
It doesn't.
who is supposed to, I think that one fact every one of us need to know. One thing to Dr. Hemant sir, as you said regarding guidelines for different setups, like see, suppose we have already done it in the past, that there are certain minimum guidelines. This is minimum mandatory standards required in the operation theatre. And second topic which we wrote below that was it desirable. So it's perfect. But how does that person who is working in a nursing home or a setup justify that this is a small setup and we had only minimal? I mean, it's very dubious in the court. We have that different guidelines for small setups and higher ones, like minimum mandatory, this is minimum which you have to have, and desirable means for upgradation. But how to justify that my setup is minimum? That is what the members would like to know.
So that is a gray area.
Great.
So
No,
that cannot be defined,
see,
but
see,
I will
at,
add to this.
I
Yeah,
just
many a
feel,
yeah.
okay, so let us just say that for emergencies, we've already seen that you can kind of, there is a lot of leeway given to you to manage emergency cases, even not up to the mark. Now, unless all of us start saying that the minimum whatever for anesthesia itself, anesthesia is a dangerous procedure. Giving anesthesia in MRI, you see every 6 months there is a death in the MRI, yet there is an anesthetist who is willing to go there without monitoring. So it is up to us in cold cases to say no. And see, today, even in smaller places, ETCO2 is saving you. So who is this person who says that 3 lakhs of rupees is not necessary? Who is the person? So now we have to really open our eyes that if it's keeping you safe, who is going to? So I think that it has to be the hospital administration and where you work. You cannot work in give anesthesia to even laparoscopy without ETCO2. We've said that in our guideline. It is for your safety. Forget the patient. It is for your safety.
Madam, next question to you. Can patient data be given to insurance people like in road traffic accidents for investigating purposes?
No, no, no.
No.
It has to come from the police, or it has to come from the court.
Yeah.
You
Not
don't
otherwise.
give it. The hospital gives it. You don't be party to it. Means because hospitals, we don't know what they are doing. Really, we don't know what they are doing. What they're doing with all the data that is collected in the thing, all our, those monitors and all, they're lying all over. Anybody can pick up patient data. Today, everybody is not aware only that patient data is so valuable.
What is
And
the
that is
importance?
why
Actually, as per Information Technology Act 2000, person who is responsible for the data has to give the data. It's not for the hospital to give data created by me. It is absolutely not acceptable.
no, hospital doesn't have to give, but the hospital is not aware that we are not supposed to give.
Okay, I agree with that.
Madam,
And they
But-
give, see, hospital is sharing data with pharma companies. That I'm 100% sure.
there are many more questions. I'm trying to finish them all. What is the importance of virtual consent by patient attenders and virtual specialist opinion is taken in emergency?
Can you repeat?
What is the importance of 1, virtual consent by patient attenders, and 2, virtual specialist opinion is taken in an emergency?
Virtual as in on the phone?
On the phone, yeah, that's what I understand.
I mean, it is as good, no? In fact, it is more of an evidence that patient has understood. You just have to put these typical lines. Have you understood? This is the risk. This is what we are going to do. Have you understood? And do you have any questions? So these are those
Exactly.
3 important questions that you must ask. And if they say yes, yes, you've got your
Yeah.
evidence
I
of
will
consent.
just suggest that you should ask them first tell them that this is being recorded, and secondly, you record it on your mobile so that it becomes admissible evidence in the court.
But remove it from your mobile and keep it, store it in your PC.
Yes,
Ma'am, I think second part was what he's saying is one is the consent one, second one is the opinion of an expert. Suppose in emergency, that expert is not there, and suppose I, in front of the attendant, I talk to a cardiologist and tell him, look, this is the ECG changes, this is the blood pressure, this is the history, and he gives some opinion. So what is the validity of that virtual opinion of expert?
See, whether you accept that opinion or not is your, and there is no harm in taking expert opinion, but ultimately you have to decide whether it is logical or not. I mean, I feel that they are, though in Dr. Ladkat's case, he said give Wolveron, right? In the Pune, Dr. Ladkat's case, he said give Wolveron, okay? And they gave Wolveron. And he was in jail for 4 days, okay? He was implicated, it was fabricated, everything. So these things can happen. So you cannot save yourself from everything. That is my...
And many times, cardiologists say that ECG, STT non-specific changes, yes, it's within normal limits, you can go ahead. But it is the desire, it is the competency, it is the individual skill of the anesthetist to take into consideration, or else he has to have his own opinion whether to accept it or not.
Sir, actually the point is...
The decision making is yours, so...
Yes.
I mean...
Just I will add what Dr. Sharma sir says asking, I think so. No, if you take any opinion, virtual opinion, whatever you have taken, if you agree and if you want to act on that, please document on the paper that whatever has been asked, that has to be documented on the paper. And if you acted accordingly, and if there is a corroboration between your thought process and the advice given, nothing will happen.
Actually, sir, the point is a little different. It is not what Madam is saying that we have to decide. It is for our support. Say, suppose in many of the judgments, the court says, why didn't you consult a cardiologist? It has been in many of the judgments. I mean, our competency has been challenged in the court. That anesthesiologist is not competent enough. He must have consulted. Such cases have gone. So it is for our safety. What I was learning from that question, it's a very tricky question. Suppose at 12 o'clock in midnight, there is a cesarean which is having a cardiac disease. Now I have to take it as an emergency case. In that case, suppose if I take a virtual opinion. So
but you write on the documents, na? That these people were consulted.
That virtual recording, but of course it will be documented in the file. The thing is that court may accept it, that we have tried to consult in emergency situation. That is what we want to do.
See, emergency, you have a lot of...
Even in emergency, the telephonic conversation, telephonic advice are very much acceptable nowadays.
Right. That is what the question was.
Practice guidelines have clearly stated that if an opinion is taken virtually by one registered medical practitioner from second registered practitioner, it is acceptable. There is specific clause for TPE and TPG guidelines.
There are many more questions to go.
Can
anesthesia be given to a patient to be operated by non-allopathic doctors?
That is not to be discussed, I think.
That is not to be discussed in the...
Even I had the same thing.
Yes.
They are doing it and it's wrong, but they are doing it, and in Maharashtra, they have been allowed to do it.
Yeah.
But we are not supposed to, as per ISA.
Exactly. We have made it very clear in our guidelines also.
Yeah.
If police lodges FIR under 1061 of BNS without expert medical opinion as part of preliminary inquiry, doctor may approach the jurisdictional high court to get FIR quashed. Question for respected panelists.
So he has answered the question himself.
Exactly.
Yes, they cannot. Yes.
What is to be...
application to quash the FIR.
I have got indemnity from 2 different insurance companies. One offering good legal support but less coverage. The other giving good coverage but possibly less legal support. Can I use both for claim? Indemnity.
Of course you can.
You must use both.
You must use both.
Is it allowed to record poor patient's interview regarding treatment or before surgery, intra or post-op, after recovery videos or pictures with consent from the patient taken by the hospital or the surgeons for his or own publicity on a pretext of discounting hospital bill or free treatment. Is this allowed? Oh God.
This is
Maybe
out of our
very big
syllabus.
topic. Very big topic. Let's not get
Totally out
into
of
it.
our syllabus.
I think
Yeah.
question related to the talk you should take them.
I know.
Those
In
what has
Dr.
been discussed.
Archana Sharma's case, why 302 murder cases charges filed?
Political pressure.
Why
Political
302
pressure.
was filed against Archana Sharma, right?
Yes.
Yeah.
Archana Sharma.
Now, not only Archana Sharma, there was a
Yes.
doctor from Satara, close to Pune,
Yeah.
and he has hospital 15 kilometers away. There was a breech delivery. He had advised section. Patient went into labor, came with breech delivery. And then the patient's relative filed a case against the doctor because police filed 304A.
Correct.
Judge in the Bombay High Court asked why 302 is not filed. That is the understanding of the High Court judge. Then the case went to Supreme Court, and Supreme Court said 302 is not applicable, 304 is applicable. So 302 is not applicable. It was a gross error on behalf of police. And I am very sorry to tell you that this case came up for hearing in Supreme Court last week, where Medicolegal Society filed intervention application in the case filed by husband of Dr. Archana Sharma. And the senior counsel who was arguing on behalf of husband of Archana Sharma said that this particular thing has happened, and 302 has also been filed against me, and my wife has committed suicide. So the court asked what has happened in the case, in that 302 investigation. So the counsel said that I am not on that point. I am on the point of 302 was not filed correctly. Therefore, police has done something illegal. They have violated Jacob Matthews. So the Supreme Court said that if the police has violated Jacob Matthews, go and file contempt petition. What are you coming in Supreme Court for? He said we want guidelines for police. That guidelines has already been given that FIR cannot be filed or arrest cannot be made. 302 should not have been filed. You go and file contempt petition. So the case was rejected. So that is the sensitivity of the judiciary. But if you see on law point, she is on dot. Firstly, you are not able to tell what has happened on 302 case for last 3 years. Secondly, why have you not filed a contempt petition, which has been done by Dr. Lalit Kumar in the case in Rajasthan, where the police has been taken to task and judge has asked the police that we will arrest you. So please remember that if any police files any charge against you, you have to decide whether you can file a contempt petition against or arrest you. File a contempt petition. What we are doing is we are trying to settle the cases out of the court, try to run away from it. We can file case against the police, and please remember Medicolegal Society of India will be there with you, 110%.
Thank you, sir. Thank you. That was a very nice, almost concluding remark. We'll take one last question now. Should anesthetists insist for postmortem in death due to surgical mistake like puncture of major vessel during laparoscopic surgery? Anyone can answer.
Can I say something? I'm not expert
Yeah, please, sir.
regarding this.
Yeah,
See, my opinion in this. The thing is, this sentence in itself. See, I told in one of the meetings in Medicolegal that one should always consider himself to be a part of the team. That includes the surgeon and the alum. Now, once you start making an opinion that, see, the postmortem will in itself reveal what was the cause of death. So why he wants to go against the surgeon and ask for postmortem? See, then he will find your mistakes. So this is a very common thing which you are going to create troubles for you. That is, I mean, I wanted to give my opinion. That's all.
I feel a lot depends on the relation that you have with the surgeon.
Absolutely.
It's always a long-term relation.
Absolutely what sir said, it is a blame. We should not indulge
No
in
blame
blame game. Number one.
Absolutely.
Number two,
Sometimes responsibility. Should not play a blame game. Yeah.
yeah, in blame. In
But
this,
at the same time,
in
it is rather difficult to not, when it's the truth, it is actually very, very difficult. Now, if there is this large puncture which has happened and we, kind of close, whatever, cardiac arrest, we close. Okay. Now, this is like a death on table situation. And the only thing is that we should not instigate. we should not instigate. And so I will be saying that there is bleeding, right? So if in my notes, what will I say? Blood pressure fell.
Yes.
So it is automatically implicating that there is a surgical bleeding problem, and I'm pushing blood. What does that
Yes.
mean? That means that there is a surgical problem. So even if I'm not implicating the surgeon, my documents are showing, and it has happened to me. It has happened to me in one table death that I had written all this. Okay, I'm pushing blood, I'm doing this, I'm doing that, whatever. Does that mean that I don't write that? That itself is enough for any. I'm not going to say that it is the surgeon's fault. I'm not writing it's the surgeon's fault, but I am saying that at 10:30 there is major bleeding and I am doing this. I'm sending tag. I'm calling for FFP. And see, in a LSCS, if there is bleeding, and if I'm writing all the notes which are related to bleeding, does that mean that I'm implicating the gynecologist?
No, ma'am. See,
Basically,
every
no.
anesthetist has to write down the notes.
Yeah,
What
so
I
as long
said,
as I'm not saying that who
see,
is responsible, I'm not
what I
saying.
said was, we all have to write down the notes. If there is a bleeding,
Everybody has to write
hypotension,
down the notes.
but the only
And
thing is, why should we go and ask for a postmortem?
no,
That is
we
what I
will
said.
not,
Exactly.
and nobody needs. See, anesthetist very rarely has to ask for post-mortem. He is in the background. Okay, it's the surgeon's patient. Surgeon will generally decide, and if it's a death on table, we've all decided that yes, the police need to be informed because
Yes.
it's an
Only thing
unnatural.
is, you have to inform police.
Yes,
Decision of
to let the
post-mortem needs to be
police
taken
do
by the
whatever they
police.
want.
So I'll tell you one more last thing about this cause of death and, you know, what you can say, medical legal case and post-mortem, etc. There was an effort from Nagpur. Indrajit Khandekar has made a categorical statement that if the doctor knows cause of death, he will see, then he should not send for post-mortem. That is a categorical statement made by Dr. Indrajit Khandekar. And Medicolegal Society of India has taken very serious view of this statement, and we conducted a meeting of about 50 forensic experts. And in that meeting, what we have decided is that we have to just tell the relatives that this is the cause of death. If the relatives want, they will go and request the police that they don't want post-mortem to happen and take consent from the police for not post-mortem, and only then we issue MCCD.
Yeah.
Okay. So the thing is, we don't give cause of death, neither we tell to do post-mortem. We say that we inform the police. That's it.
This is to avoid the unnecessary postmortems. In the meantime, if the patient relatives agrees for that, they accept the cause of
So
death. They
forget it.
don't want no, even otherwise, if they don't want the postmortem, take a writing from them, undertaking, and send the body. That's what that Indrajit and the MSI
That
have
should
decided,
be
right?
that should be through the police, not directly. Because deciding post-mortem or not is the
Is
duty
not
of
done.
police and not of the
Correct.
doctor.
Police also should sign. Police also should record it. Yeah.
See, police
Either to
wants to
police or
reduce their
purpose.
work. These forensic people want to reduce their work and put the entire onus on the doctor. So that is not acceptable to anyone.
I feel all medical legal webinars can go on and on and on for the next 3-4 hours. I'm sure all the panelists will still continue answering the questions. I feel we've had a wonderful discussion, and I
think we
feel
need
it's
to
time
partner.
we should it's time we should put a stop somewhere. I'll
Yes, sir.
request our Vice
Okay.
President, Dr. Virendra Sharma, sir, who was actively involved in the discussion also, to please give his suggestions and comments. And if anyone else in the audience wants to just give his comments, maybe we can just take a few lines. Dr. Virendra Sharma, sir, please.
It's a very important webinar, but I was thinking from point of view of a freelance practitioner. The second, third, and fourth speakers, see, knowledge is all okay and all, but these are all nightmares for freelancers. If a death in OT happens, or there is a case filed, or arrest, something like that. So I wish no one faces that, but for that, look, first thing is at least take a professional indemnity. See, the biggest thing is nowadays compensation awarded is very high. And we all know anesthesiologists don't earn that high. The compensation is highest but earning is a little lower as compared to the others. So everyone should take professional indemnity. The second important thing which I noticed was written that ignorance of law is no excuse. Now that means whatever provisions that we have to do this, we have to do that, we all are supposed to know. And I know for 100%, majority doesn't even know that this has to be done. So ignorance of law, that means we all must be educated what is to be done in a crisis moment. And third thing is regarding that declaring, I think one important thing in the chat was, yes, majority of us do shift the case to ICU, and after some time we declare there. We don't declare death in OT. So that is no harm. I mean, it has some safety measures for us. So I think that point was mentioned there. And another important thing, Dr. Kumar said that legally we are not supposed to inform the police in case there is a DOT. Till now, I was of this concept that every death in OT is inquirable. I had this misconception. Today you have cleared that. So a very informative webinar, and we keep on doing. But I think it is for the members also to read all these things. And again, ignorance is no excuse. We must know what we are supposed to do. Thank you so much.
Thank you, sir. Thank you, sir. Anyone from the audience would like to, someone raise their hands? 1 plus. 1 plus 5. You can please unmute yourself. Yeah. Yeah, please go ahead. Please speak, Mr. 1 plus. You are unmuted.
I think he is not there, sir.
Yeah.
No, he's there, but
might
he
be
is unable
temporarily
to.
not there.
Yeah.
His hands was raised.
Yeah, still raised.
Yeah, I think you can conclude, Pankaj.
I feel we can conclude. I feel it has a wonderful discussion. As I was expecting the discussion to go on to maximum 8, but it's already now 8:25. I should first of all thank my national secretary who's really been waiting with us. I mean, it's because usually we expect the webinars to get up in 1.5 to 2 hours. I feel he's been there still right till the end. Thank you, Dr. Bajwa, for everything. The 4 panelists, I mean, there are no words to say. You 4 have been wonderful. Dr. Kane Madam, Dr. Rajiv Joshi, Dr. Shiv Kumar, and Dr. Hemant. I mean, wonderful discussion and good take-home messages. The recording will be available on the ISA NHQ website always. And anyone wanting to go through it can always have a look at it.
Not on the website, man. Not on the website. YouTube.
On the YouTube.
At ISA NHQ.
YouTube. On the YouTube.
You should know the channel of the ISA now, na?
Yes.
YouTube channel.
Yes. It's on YouTube. It's always there.
Okay, thank you.
Okay. Any remarks from you, Dr. Bajwa, sir?
Wonderful things are going on. Why you want my remarks? Everything is going well, na? So if I give remarks, then you will feel bad. I have everything going well. I think whatever the inputs were there today, 2 or 3 inputs I wanted to think, but I think other people asked the same question, so all were answered well. So nothing, and I think that these are the part of our team also, our special ISA National Legal Cell also, they are the part of that. And we are proud of them. They are giving good advices. And recently we had that one incident at Kolkata, where I think Dr. Pratibha Kane, Dr. Shiv Kumar, and all those people contributed a lot. And ultimately, it ended up in a very good way, and things went very well. And people reposed the faith in the functioning of the ISA National, how even the legal help was provided in a very, very warm way. And even the SRs and the PG students, they were very happy with the support they got from the ISA National. Nice. I think that's the way to go forward. And we are very happy and proud to have such a good team and good work going in ISA National, on the Medicolegal cell. Thank you all the parts of the Medicolegal team. And please continue to provide support and help to our ISA members in the future also.
Definitely.
Thank you. And thank you all the audience for being so patient.
Good night.
Almost
we
8:30.
Always end by saying long live ISA.
And yes, long live ISA.
Long live ISA.
Long live ISA.